Thank you so much for your introduction. I'd like to thank the organizers and especially Dr. Shang for this nice invitation. I'm really happy to be here today. So my intention today is to perform a critical analysis of oocytes and embryo vitrification, but I mainly focus on the oocytes. So vitrification is an essential part of today's assisted reproduction because it has allowed the establishment of different strategies that were not available before the introduction of the technology. So egg banking is been, Egg banking has been really useful to easier the logistics of ovum donation programs without altering the success rates. Fertility preservation has been increasingly applied in clinical practice. The option has been also useful for management of poor responders and in many other clinical situations. And on the other hand, embryo vitrification, today the vitrification of the biopsied blastocyst is a fundamental tool in PGTA programs as well as the freeze-all strategy. So no doubt improved embryo vitrification programs has allowed the IVF segmentation by allowing the embryo transfer in a non-stimulated cycle. But it's been quite a debate about if this strategy is able to improve the IVF outcome. And I think that lately it's becoming clear that it depends on the population. According to this very recent meta-analysis by Roque and co-workers published in Human Reproduction Update, it is not freeze-all for all because the success rates in terms of live birth rate, they found no difference among the population doing freeze-all and the fresh embryo transfer in terms of live birth rate. But the strategy was useful to lower the risk of OHSS, of course, and higher outcomes were achieved in hyper-responders and in PGTA. So in these PGTA cycles, what we do is we vitrify the biopsied blastocyst. And I would allow me to say that the biopsied blastocyst is kind of a special blastocyst because it has they are like more exposed to the action of cryoprotectants because they have a hole in the zona pellucida, and there is evidence that the process of dehydration and the permeation of cryoprotectants may be modified in these embryos. So the question rises here whether there is a compromise in the embryo viability after the biopsy. So this is data from our lab. We have analyzed success rates in terms of survival and implantation according to the degree of expansion of the blastocyst after the biopsy. So this is collapsed, and this collapse is of course induced by the biopsy, and we vitrify them like in this stage. They are initially hatched or they could be fully hatched after the biopsy. So here is the data, also according to the morphology of the embryo and the day of embryo development, day 5 or day 6. And as you can see, best case scenario is when we have top and good quality embryos on day 5, and this is true for survival and implantation. And worst case scenario is we have, if we have the average quality embryos on day 6 and if they are fully hatched like this. These observations have been confirmed, or these authors from Italy, this Italian study from Simadomo and co-workers published in Human Reproduction 2018, they found very similar observations. So they have analyzed the risk of degeneration after warmings and the risk of not re-expanding after vitrification, and I'm good. The risk of degeneration after warming and the risk of not re-expansion after warming. So they have concluded that this is not working. It's not working, not backwards, not forward. So if I can get any help.
Just stop clicking for a minute. 1 second.
So they have concluded that, that the TE biopsy did not impair blastocyst warming survival and the behavior, that the lower post-warming survival was related to the poor quality of the embryo and not to the biopsy. And they also recommend the prevention of the re-expansion after vitrification. So we need to vitrify them, still collapse it, just to increase the success rates post-warming. But it's not only re-expansion. Now the video is not working, so but it's okay. It's not only the re-expansion post-warming, but the time that it takes to the embryo to re-expand again. So according to this study published by Coelho from our group in 2017, when the re-expansion takes like around 5 hours, implantation rates are higher. And this is true for PGT, for non-PGTA cycles, and also for PGTA cycles. So it is around 4 to 5 hours for re-expansion, and then we get the higher outcomes. So allow me to go on with oocyte vitrification, which is actually the most challenging cell that we can achieve good outcomes with these cells. So I think we have several targets, and we can focus to perform a critical analysis of the success rates we are achieving with oocyte vitrification. And these are listed here. We can analyze survival rate, embryo development, and blastocyst formation, the yield of the cycle in terms of the oocyte we need to achieve efficient success rates, and of course the clinical outcome, and I'm going to focus on the live birth rates. So to start, as for survival, here you have a different survival rates reported by different authors. You can see a kind of variability, but I can say that this is probably because they were using different technologies and different devices for vitrification. And let's say it, the protocol and the device is an issue, but even in large, well-established organ donation programs with vitrified oocytes, we have to face unexpected survival failure in this highly selected population of young healthy women. So survival failure exists. So, and we published this in 2015 in this study, in which we observe a proportion of cases in which survival was 0%. So none of the oocytes survived. And this is something that we find, and also suboptimal survival rate. This is updated information from the donors in a 10-year period. So it is up to 13,000 donors doing more than 30,000 warming cycles. And as you can see here, in a 2.6%, almost 3% of the donors, we observe this total survival failure, 0% survival failure. So this is really unexpected. And the most interesting thing is that it seems to be a repeating pattern of the survival failure in the same donor. And we have analyzed, we have calculated the risk of this survival failure, which is increasing in subsequent warming cycles. So for example, here, the risk of having survival failure in the third cycle for the same donor, if there was failure in the second and in the first one, is multiplied by 5. And I don't have the data here, but which is even more interesting, is that this donor could perform very well using fresh oocytes. So there is something related to these donors in which we cannot achieve survival, good survival rates. So in this study we published in 2015, we tried to identify the variables that we thought could be related to survival rate. So let's begin with the number of oocytes in the cohort, but as you can see for this R square here, there is no relationship in the number of oocytes and survival rate. So you can warm up like 3 oocytes or 30, this is not related to survival rate. We also analyzed some donors parameters like body mass index and stimulation parameters. None of them were related to survival, and nor was the storage, the time of storage for these oocytes, not for implantation and not for clinical outcome. This is for donors, and we found very similar outcomes in autologous oocytes, and this is fertility preservation population, elective or social freezers, and in cancer patients that we have warmed oocytes that have been stored for up to 8 years with no any change in survival rate, so long-term storage is not an issue related to this outcome. We should expect that the oocyte morphology would be related to survival rate, but according to this study published again by Coelho from my team, 2019, survival rate, blastocyst rate, and the percentage of usable blastocysts is not related to oocyte morphology. So this is not related to this issue as well. So we have analyzed different parameters, none of them related to survival rate. So let's bring the indication to the analysis and let's see how it relates with survival and clinical outcome. This figure here is extracted from a long table that was published in this special issue on fertility and sterility to celebrate the 40 years of IVF. And I have I'm showing here the survival rate for 3 different populations using vitrified oocytes. So we have donors, elective freezers, and poor responders. And in green, we have data for young women. As you can see here, survival rate correlates, is similar when we compare donors and elective freezers. But in poor responders, same age, survival was statistically lower. So it is probably due to these patients are infertile, so probably it is oocyte quality, not morphology of the oocyte, but something in the oocyte that is responsible for this lowering in survival rate. And among older patients, results are comparable. This is a complete table, as just mentioned in this publication, but I have added the original, does not include cancer patients, but I'm including here just to have the whole picture of all the women using vitrified oocytes. So if we focus on the older patients, so results are comparable, as expected, these are older women. But if we focus on the young women, a very similar finding that I just mentioned with survival rate occurs. So clinical outcome and in terms of pregnancy and cumulative life birth rate is comparable between donors and young freezers, but poor responders achieve lower clinical outcome as well, same age. And the worst, the lower reproductive outcome is achieved by cancer patients. So we thought at that time that this is probably, these are young women, these are young women as well. So we thought at this time that this could be due to the presence of the cancer disease itself, because it's been said that cancer is a systematic disease, so it is probably related to the poor reproductive prognosis here. But as we shown here in this article we published last year in Human Reproduction, again, the results are lower in cancer patients, but as shown in the multivariable analysis, in the logistic regression analysis, we failed to confirm the specific role of the cancer disease, either in the low survival rate or in the lower cumulative life birth rate we achieve. So we can say that cancer patients, they achieve lower prognosis, but so far it is not related to the cancer disease itself. What we really were able to show and to demonstrate, as shown in this multivariable analysis, is that age is the most powerful variable related to success rate in this fertility preservation population. And we published this earlier in our study in 2016 in elective fertility preservation patients, and as you can see here, the younger the higher the results of survival rate and the clinical outcome as compared with the oldest. So age is really an issue here. I think, and I just mentioned at the beginning, that embryo development and the quality of the embryos originated after the use of vitrified oocytes is also a good target to critically analyze the strategy of oocyte vitrification. So first versus frozen, is it the same using embryos from vitrified oocytes or from fresh oocytes? And to analyze this, I think we can focus on morphokinetics, aneuploidy rate, and the blastocyst rate, blastocyst formation. We published this study. Again, the video is not working, but I think it's okay. Oh no, now it's working. This was published in 2017, and we analyzed the morphokinetic parameters of embryos achieved with vitrified oocytes and with fresh oocytes. And as you can see here, there is a delay in about 1 hour in the vitrified oocytes, in the embryos from vitrified oocytes, and the differences were statistically significant. However, when we analyze the CC2, which is the second cell cycle, the moment when the DNA replicates, the results were absolutely comparable, and this is important because our thought at that time was that there is not really that the vitrified embryos are slower, but they start later to the development, and then they re-engage, and when they reach the blastocyst stage, the morphokinetic parameters are comparable, so they start later. The classification in the hierarchical tree published by Meseguer and co-worker was comparable between fresh and vitrified oocytes, and the implantation rate was as well comparable. What could be the reason for this delay in the vitrified embryos, in the embryos from vitrified oocytes? There is evidence that there is a change in the mitochondrial activity in vitrified oocytes and a high redox stage in these oocytes. So it is probably that they need like a higher ATP, a higher energy charge to re-engage with all the metabolic pathways that they need to begin development. And this could be, and this is of course a hypothesis, this is totally a speculation, but we think that this could be related, as well as there is evidence of changes in imprinting errors and changes in the DNA methylation in vitrified embryos from vitrified oocytes, and all of this is related to embryo development. So we think that the reasons for this different morphokinetic behavior could rely on this any of these reasons. But as I said, this is speculation. With regards to aneuploidy rate, Foreman and co-workers shown in 2012 that there is no increase in aneuploidy rate in embryos from vitrified oocytes, and we've been able to confirm this data in our ovum donation program. As you can see here by the odds ratio here, the probability to have an aneuploid embryo is not related to the source of oocytes, fresh or vitrified, and it happens as well for autologous oocytes, where the age is again the most important factor related to aneuploidy, as all we know. What about the blastocyst formation and embryo quality? This was published like over 10 years now, in 2008. And at that time, this was a small study, and we observed comparable cleavage rate and blastocyst formation between vitrified and fresh oocytes. Well, later in 2012, the same study I just mentioned, Foreman, showed that there is a lower developmental potential in vitrified oocytes, lower blastocyst formation and lower usable blastocyst. This table summarizes some of the reported blastocyst rates from different authors, and some do not find statistical differences, and some of them they do. This is from our clinical setting. We have analyzed the blastocyst formation in our ovum donation program, and as you can see here, it is 70% for fresh oocytes and 55% for vitrification, and differences are statistically significant. So we have lower blastocyst formation with vitrified oocytes using donors. although the clinical pregnancy was comparable. And when we did the multivariable analysis, we confirmed this, as you can see here, but this odds ratio, the blastocyst formation is related to the source of the oocytes, fresh or vitrified, but it is as well related to the number of oocytes microinjected, as you can see here. So we bring the issue of the number of oocytes. This is data, again, in open donation, showing that the more oocytes, the higher the outcome for fresh and for vitrified oocytes as well. And this is the logistic regression analysis showing that pregnancy rate is not related to the source of oocytes, fresh or vitrified, but again is related to the number of oocytes microinjected. And this is this study, which was presented in the last ESHRE. It shows exactly the same observations. So this is from Rodriguez Aranda, from Barcelona in Spain. So they have analyzed the overall ongoing pregnancy rate and live birth rate in the overall population, and they found differences between vitrified and fresh oocytes, but when they adjusted by the number of oocytes microinjected, then the differences disappeared. And this is the multivariable analysis just confirming this. So as I am saying, and this is in their own authors' words, IVF with vitrified oocytes provides similar reproductive outcome to fresh when the same number of oocytes is available for microinjection. We also addressed the issue of the number in this publication with donors. This is the cumulative live birth rate according to the number of oocytes used by the same recipient, and they exponentially increase as we add more oocytes. So the more oocytes, the better. And this is also true for elective fertility preservation, as we published very recently in our study. And of course, we use in autologous oocytes. It depends on the age of the patient. And this is the last issue I would like to at least mention in this talk, which is the reproducibility. This is from our group. This is cumulative live birth rate in 10 years using vitrified oocytes. And as you can see here, sometimes at some points we found statistical differences between fresh and vitrification, but overall calculation, overall data is comparable. So we can say by this is cumulative live birth rate, which is what we really pursue during assisted reproduction. We don't need pregnancy rates or ongoing pregnancy rate. We need a baby. So I think by this information we can conclude that this is consistent. This is 10-year period, and these are huge numbers. But this is a study published by Kushner with SART data showing declining live birth rate in 3 years using vitrified oocytes for donors, egg banking for organ donation in the US. So why? What is this? What is happening? Why in this very large registry we are seeing this? Well, these are their own authors' words. Oocyte damage. This could be caused by oocyte damage after vitrification. Donor selection by commercial egg banks. Smaller allotments. Remember, we just mentioned the issue of the number, which is really, really important. In the lower number of oocytes in the vitrification as compared to fresh, and also the issue of transportation, which I think this is very interesting, but we don't have time to address this issue now. We cannot deny that there are technical issues related to vitrification. This is a very it's very closely related to the expertise of the embryologists doing this. And during all these years, I've seen many people I thought at the beginning doing absolutely completely a different thing. So they changed the protocol. I don't know why we embryologists like to contribute, to give our personal contributions to the protocol, and at the end it's a distorted thing. So this is not the thing we have to do. So I think this is linked very well with our next speaker, which is that we need to face this lack of reproducibility among different laboratories with regards to vitrification. This is a technique that really works, can be consistent, but it doesn't work in every place. So this is something we need to address. And of course, I think, as Pasquale as well, that maybe automotion is the answer. So this is my last slide. I would like to just summarize all the things that I've been mentioning during this talk. Freeze-all is feasible thanks to improved vitrification, no doubt. The TB biopsy does not impair the vitrified embryo, and we need to prevent for re-expansion before vitrification to achieve higher success rates. Oocyte vitrification provides efficient results. The source of oocytes, and I think this is really important, we have to keep in mind, fresh or vitrified is not related to pregnancy or life rate, but there are some limitations. We need to face an expected survival failure even in donors. Lower blastocyst formation. They can be different endodevelopmental parameters, especially due to subcellular effects of vitrification. The number of microinjected oocytes is also a limitation or an issue if we need comparable outcomes between fresh and vitrified oocytes. Survival rate and clinical outcome are related to the indication. We have doing this in different populations, and we need to keep in mind, especially when we are counseling fertility preservation patients, the number of oocytes is something that we really need to keep in mind when we are counseling these patients. Infertile patients achieve lower outcomes when compared to healthy women as donors or young EFP patients. Cancer patients achieve poor reproductive outcome, but we don't know yet if this is, we're not able to confirm that this is due to the cancer disease itself. Age is the most powerful confounder, and there's the issue of reproducibility. And that will be all. Thank you very much for your attention.
Thank you, Anna, for a wonderful lecture and great, review of the techniques and what can happen, what can we do. We have a few minutes left, so we're going to entertain some questions, if any. If not, can I ask you a question? We know, like age, is the critical factor. And yet, we have to balance, for social egg freezing. So we have to balance, whether what the practical time of preservation, because we know that women have better chance to work, to education, they're marrying later, and yet, so if we get them to preserve the eggs too early, they probably won't use it because, they will get married. Mm-hmm. And if we get them to preserve the eggs later, then the effect will be less and the success rate is less. So what, in your opinion, if your experience, what would be the ideal or the optimum age that a woman should consider preserving the eggs?
Oh, well, this is at the first glance, I could say that this is an easy question, but in the practically it is not. We know by our analysis that higher outcomes are achieved if the patient is 35 or younger. But the mean age of our patients doing elective fertility preservation is like close to 38. So it means that every day we have in our consultation older women asking for this option. And as I have shown you, we can achieve, they can achieve success after the fertility preservation. So we cannot say no to these patients because they have achieved a baby even with 40, 41, 42 years old. What I think we need to explain them very well their possibilities according to our experience, and I think it is important that everyone, I don't know, maybe start constructing their databases and their own experience. So to answer your question, younger than 35, but not too young, because of the issue of cost effectiveness. So they.
That's right. Well, you know, I think it's obviously it's also up to someone has a question, Pasquale.
Anna, thank you very much for your talk. I'm wondering if the practice of selling eggs from egg bank, which is currently in the United States, they sell 6 eggs per patient. Mm-hmm. Is that number sufficient, given your slide showing that really the number of eggs is what is really important? So generally they sell 6 eggs per patient. Is that number sufficient?
If you are asking me what I would like if it was me or my sister or whatever, I would prefer more than 6, of course, 8, 10. But I know that this is a complicated question, of course, because there is I know that commercial banks need to exist, but I feel more comfortable doing if they could increase the number.
Thank you.
This is my very personal opinion, because with 6 oocytes you can achieve 1 blastocyst, 2 blastocysts if you are lucky. If not in the first, in the second you can get the pregnancy. That's for sure. But the more, the better.
Now, one last question, Seth.
Freezing eggs is like an insurance policy that nobody wants to use. Nobody wants to use insurance policy. Do you have any policy what you are doing with the extra eggs that people don't want to get back? You know, if they are becoming married, if they are married, they're using their own child, they have lots of eggs in your bank. What do you do with these eggs?
I have to say that we haven't faced this situation yet. Because this is 10 years using it since we have elective freezers in our tanks, so we have been.
So you're not getting the patient to sign a form
that they
consent?
say I don't want to use them. No, but I mean this is strictly regulated by law in Spain. After, if I remember well, it is 5 years. We contact them to ask them if they need to keep like paying for the maintenance of the oocytes in the bank, and if this occurs with embryos. As I'm telling you, not yet for oocytes. If they don't want to keep them, they need to sign a consent form. In the case of embryos, if they donated them for other couples for research purposes, or if they want to discard this. And personally, this is something that we will need to do with oocytes as well.
So do you have any policy to destroy eggs if you cannot have contact with the patients?
Not a clear policy yet. But I think that as this is regulated by law, this is that we will do.
Well, you know, this is, of course, you know, a very pressing question, situation. You know, it's a very interesting, and I think Anna has given us a good lecture. And any other question, because of time, we have to ask you to approach Anna and coffee time. Thank you very much.
Thank you.